Hello, my name is Santos Moreno. This is going to be an assessment video for the thorax and the heart area. And with me today I have Miss JG. She's a 28-year-old female. And we're going to go ahead and start off with the thorax area. All right, so of course with any assessment you want to go ahead and get your history first. History with, any complications, any family history that the patient may have. And you want to do your inspection, palpation, percussion, and auscultation with your with your systems. So first, we're going to go ahead and start off with inspection. So visualizing your patient, and a lot of times, especially as a male, you're going to have a female patient, and it's best to have a female present, just for the comfort of the patient, not for necessarily anything else, but of course, for legal reasons. You want to go ahead, make the patient comfortable. And the reason I mention that is because you want to visualize the patient without a gown. You're going to be seeing, is it skin intact? Does she have any lesions, any drainage, anything like that in her chest area, especially with a female with her breasts. So you want to assess that very thoroughly. So with inspection, you'll see the patient's thorax. Is the patient breathing right? Is she using axillary muscles? Is she using abdominal muscles? Is she retracting? Is she breathing right? And a lot of the times, you'll see and hear the patient, wheezing. You'll see them, gasping for air. You want to visualize the nostrils. Are they even? Are they flared? Is she having difficulty breathing? You want to go down to the trachea. You want to assess the trachea. You want to see, is it midline? Is it not midline? And you want to go down to the thorax area and continue your visualization. See if you see any abnormalities with that. With palpation, of course, you want to start from the top and then work your way down. So with palpation on the trachea, you want to feel if there's any deviation to either side. And a lot of the times with these patients, when you have them on med surg or tele patients and with ICU patients, it'll change considering that a lot of the ICU patients will be intubated. So you'll see the ET tube from the mouth go down, and you want to assess your x-ray as well. A lot of the time, some of the nurses neglect seeing the x-ray, and that'll give you a lot of information as to what's going on with the lungs. So with palpation, sometimes you'll even feel, if the patient has crackles with a patient with ARDS, and, decreased lung sounds on the other, you won't see some of the chest rising. And with the pneumothorax, you'll see that, and you'll feel that with less and reduced lung sounds on one side or the other, and you'll see one side of the chest rising more than the other. With percussion, of course, you want to start off with the top going down. You can percuss the front, but with the right side you have 3 lobes, and with the left side you have 2. You don't want to neglect above the clavicular area, and then go down to the base on the lungs, and then move your way to the other side. And a lot of the times you don't, with ICU patients, they're very dependent, and you can't have them turn around. So most of the time, the med surg and tele patients will be able to do this, where they'll have them turn around, and you can percuss, you can palpate, you can do your tactile thermometers, see if it's equal on both sides, check the lung sounds, and then moving on to the auscultation. You want to do the same thing. You want to start from the top, work your way to the other side, go down, work to the other side, go down, and just using your landmarks, going down to the baseline on the lower thoracic area where the floating ribs are, and coming back to the front, the anterior side of the patient. You want to auscultate from the top of the clavicular bone, only because the lungs start from the top and they go all the way down to the base, which is over here, down to the lower rib area. And you want to check, is there crackles? Is there lung? Are the lung fields intact? Is one more than the other? Any decreased lung sounds? And especially with a patient that's intubated, you'll see a lot of the times. The doctors, they'll check the X-ray first before anything else to see if there's any deviation from the ET tube that, it goes down to the carina. Is there deviation to one side or the other? Is it positioned right? And a lot of the times you'll notice that when they intubate a patient, they'll go back, they'll order the chest X-ray right after. And if there's any deviation, one side of the lung, or one of the lungs is getting more oxygenation than the other, and then you end up having a pneumothorax and you have more complications like that. So assessing a patient, especially in the ICU area, is very, very important. From either visualizing down to auscultating and then checking your images. And especially, like I said, especially the X-ray. Now, going down to the heart. Of course, you're going to start from top to bottom with inspection. Well, of course, you're going to get your history. With the inspection, you want to check your patient's JVD. Is there any distension? Is there any distension? Is there distension on both sides? Is there anything else going down? You're going to visualize the patient's the hand. Is there clubbing? Is there clubbing in the area? Is there the capillary refill less than 3 seconds? Is it more than 3 seconds? And of course, moving on to palpation, you're going to palpate. You can palpate the carotid. Are they the same? +2? Is it +3? Or even +4? Is it bounding with the JVD distension with patients that have that? Excuse me. You want to go down to your radial pulses, your ulnar pulses, the femoral, dorsalis pedis, posterior tibialis, and the popliteal pulses as well. And upon palpation, is the patient cool? Is the patient sweating? Is there any edema? Going down to the extremities, you'll feel the femoral. Is it equal on both sides? Of course, you want to check your other hand as well. And moving down, a lot of the times with patients that have CHF and other heart problems, you're going to see edema, pulling down on the ankles. Their pulses are going to be reduced. It's going to be like a +1, or sometimes even so that you have to use a Doppler to assess your pulses. And, a lot of the times with the CHF patients, you're going to see reduced hair on the extremities. You're going to see it shiny. You're going to see it, thin skin. And, that's just something to keep an eye on, only because some of these patients will, like as I mentioned before, in intubating patients, they might not necessarily have CHF, but because they're not moving, all that fluid is not going to be circulating correctly. And these doctors will prescribe, will have them give them, some kind of diuretic, the Bumix, Lasix, and what have you. And you have to assess that, and you have to check your urine output, check your pulses again, check is edema less, and you just continue on with your assessments from a day to day, and report your findings to the next nurse. With percussion, you don't necessarily have to percuss your chest again for the heart, but moving on to the auscultation, you want to auscultate using the bell of your stethoscope, and you want to assess the carotid, see if there's any bruits, any murmurs, anything like that. Is there any abnormalities from one side to the next? And you want to auscultate, going down to the apical pulse. Now with the auscultation with a female, again, you want to make them feel comfortable. You have to tell them what you're going to do with any assessment with any patient, male or female. You want to tell them what's to be expected, what you're going to be doing, especially when you're going to be assessing the thoracic area with a female. You want to see, okay, does she have any breast implants? Is she okay with a male assessing the apical pulse? Because with the apical pulse, you want to go mid-clavicular on the left side, go down to the 5th intercostal space. You want to lift up the breast with the top part of the hand, put your stethoscope under there for a whole minute, and assess your pulse, assess if there's any abnormalities with the pulses, comparing them to either your monitor, or comparing them to your other pulses using the radio, ulnar, femoral. And as far as the thoracic and the heart, that in your assessments goes, that pretty much covers a general aspect of what's going on with your patient, just to have a general overview. And of course, you have your labs, and you have your chest X-rays, your CTs, and all that stuff going on. Your ultrasound for the heart to check an ejection fraction, and that'll give you more in-depth information with the patient. Now, just a quick overview with the breasts. It's a lot of information with the breast, especially with a female. You have to teach them and do some advocating for the patient for teaching. You want for them to learn how to give themselves a self-assessment. Preferably it's in the shower where, they can have a little bit of self just to kind of glide a little bit easier with a circular motion going down to, this one right here. So you want for them to start in the axillary area, just go down around the breast and just slowly in circles go down to the areola and the nipple. So you can have them, practice in front of you. You can, tell them what some of the abnormalities, or if they even have any abnormalities, and you want to have them do it on both. A lot of the times, upon inspection, you'll see one droop more than the other. You'll see, something, distended. It could be, a pacemaker. You don't even know, but that's just part of the questionnaire that you have to ask. Does the patient have any breast implants? Sometimes the patient might not even, do their self-assessment properly, and, you're checking yourself, and it's like, oh wait, one of the breast implants have popped or something like that. So, all these questions come prior to your assessment. With palpitation, you want to continue with the IPPA palpation. Is there any drainage? Is the breast warm? Are they sweating? Or are they warm? Is there any discoloration, any redness, anything like that? Especially with the female, of course, you want to do the same with your male patients. Only because males can get breast cancer as well, and they can get lesions. They can get any masses as well. With percussion, you want to start and from the top, go down and see if there's any abnormalities with, it goes in conjunction with the thorax, see if there's any distortion with the lung sounds or anything like that. But again, you want to see, is there sufficient vascularity with the areolas? Are they intact? Is there any drainage? And it's good to tell the patient, when you're doing your self-assessment, you want to look at your breast. Are they even? And if you have any doubts in your mind as a nurse, you can get a tape measurement. A lot of the times with the females, their nipples might not be symmetrical. One might be lower, one might be higher than the other, and that's normal. But a lot of the times it could be something a little bit more significant. It can mean that there's a lesion or there's a mass attached to the tissue that keeps the other one lifted. And there's another self-assessment that they can do. They can press their hands under hips, and that causes the pectoral muscles to flex, and it should pick up both of the breasts. And if one picks up more than the other, then that could be something that we have to keep an eye on. Same thing with having the patients lift up their heads all the way up, and the breast should move equally. If they don't, then we want to further assess that as well with either an X-ray or a CT scan or an MRI. And going back to the drainage, you want to have the patient squeeze their nipple, see if there's any drainage, but at the same time you don't want for them just to do that, because the glands start lower and start behind the nipple. So you want for them to kind of grasp the breast, squeeze it a little bit, just kind of like if you're milking the breast, and see if there's any drainage. If there is any drainage, it might be that they could either be breastfeeding, or there could be some kind of infection. I know I've had a patient like that she did have breast implants. She ended up getting some drainage out, and it turned out that it was a bad breast implant, or something just went wrong with an infection. Now, of course, you want to self-advocate with the patient, not just for the breast, but for the whole assessment, going back to the thoracic and the heart. They start feeling palpitations. Are they eating correctly? You want to teach them the signs of something that something is going wrong. And pretty much that's it. I want to thank my partner here for helping me with the assessment. And if you guys have any questions in regards to a further breast exam or further breast self-assessment or anything like that with the thoracic area or with the heart, just go ahead and leave some comments, and I'll be happy to respond. Thank you.